Well, greetings everyone, and welcome to the EKG case for the week of November 25th, 2013. Before I get started, I just wanted to make a couple of introductory points. Please note the website for our residency where we post these cases. A lot of people have emailed me after watching these things on YouTube, and as great as YouTube is, it doesn't contain all of the summaries that we post on our residency website. Our cardiology fellow, Dr. Ali Farzad, has done some amazing things with that website. So if you want to get the full content of these EKG cases, please go to www.ekg.umem.org. You'll see the videos and a lot of summaries and diagrams and a bunch of other really great things. Second point, I put my email on every one of these videos because I am completely happy with getting videos from anybody who has any questions or wants to share cases. And despite that, a lot of people go through a lot of trouble trying to find my email off our residency website. Don't bother. It's complicated. It's longer. I don't check that website as much or that email as much. Please just email me at this email. All right. That's why I put it on every one of these things. And also, if you're a Twitter person and you follow this Twitter handle, every Monday when these cases get posted, I send an email or tweet, I guess, out to everybody just to let them know about the cases that get posted. So just a few points there. Okay, now let's get on to the EKG case of the week. Actually, it's a series of cases that all have a common theme. This first case that we're going to get started with was sent by paramedic Mattu Ball. He's a firefighter and a paramedic who works near Seattle, and he had a 34-year-old man that presented to his service, or his ambulance, I guess they call 911, for palpitations, chest pain, and shortness of breath. And this guy had a fairly scary-looking 12-lead EKG. First thing you'll notice, it's irregularly irregular. So let's agree, first of all, on calling this atrial fibrillation. And let's also agree that the EKG machine is stupid and oftentimes has no idea what it's talking about. A flutter with variable conduction. I think you'd have to look long and hard to really find some good flutter waves that map out really, really regularly. But anyway, we'll move forward. The other thing that you'll notice about this is that the complexes are wide. And so, yeah, maybe right bundle could be a consideration. And if you look at V1, there's that taller right rabbit ear, which oftentimes leads us to think that this is a right bundle. But one of the key points here is that the morphologies are changing. Some are wider, some are more narrow, and in some places the rate's getting really, really fast, up to 250, 300 beats per minute. And when you see AFib with morphologies that are changing and rates approaching 250 or 300 beats per minute, that means that you're probably dealing with an accessory pathway, WPW being the most common form of accessory pathway pre-excitation. And Matthew was all over this. He was worried appropriately about atrial fibrillation with WPW, and he knew that AV nodal blockers, right? Typically with AFib, you want to give calcium channel blockers, beta blockers, DIG if you're not in a hurry. What else can you give? You can use amiodarone. All of those are AV nodal blockers, and he thought about that with normal AFib, but he knew that when you're dealing with WPW and AFib, all AV nodal blockers are contraindicated. You're going to kill patients. So he stayed away from them. They got the patient to the hospital quickly. The patient was relatively stable. In the emergency department, the folks there were on board as well. They sedated this patient. They cardioverted this patient, and the patient ended up having an excellent outcome. After cardioversion, they confirmed the presence of WPW. The patient went to the EP lab and had, I'm assuming, ablation and had a pretty good outcome. So that leads us to talking about atrial fibrillation with WPW, a continuation of last week's WPW discussion. If you didn't see last week's discussion of WPW and then SVT with WPW, please review that because I'm going to skip over some of the basics. We're going to jump right into AFib with WPW. And as I said last week, that's the real killer that you've got to know. And oftentimes, it's a killer from an iatrogenic standpoint as well. So let's first of all talk about normal atrial fibrillation. We've all seen this many times before. With normal atrial fibrillation, you've got an atrium that's beating 300, 400, 500, 600 times per minute. By definition, that's what fibrillation means, right? So the atrium is beating anywhere up to 600 times a minute. It's sending impulses down to the ventricle, but how fast does the ventricle normally beat when we see new onset rapid AFib, right? Normally, we're accustomed to seeing the ventricle beating maybe about 150 beats per minute, maybe 180 or so, maybe up to 200. But really, it's very unusual to ever see a rate faster than 150 to 180. This is the typical rate. So the atrium is beating 400, 500, 600 beats per minute. The ventricle's only beating less than 200. Have you ever wondered what happened to all of those other impulses? What happened in this region right in there? Well, I'll tell you what happened. The heart has a very protective structure called the AV node. And when the AV node sees too many complexes, it just kills them. So a whole bunch of impulses are coming down and getting conducted normally, and most of the complexes are just getting squashed right there in the AV node. And the result is that the ventricle in normal AFib only beats about 150 to 180 times per minute. Okay, so now what happens when you have an accessory pathway? As we said last week, notice the accessory pathway has no AV node. It is all too happy to conduct everything it sees. So what's going on with WPW and AFib? Once again, the atrium is beating 300, 400, 500, 600 beats per minute. Some impulses are making it down through the AV node and getting conducted narrow. That's my narrow, by the way. Some impulses are going through the accessory pathway, a lot of them are, and getting conducted wide, okay? And they can be very fast because that accessory pathway can conduct very quickly. And a lot of impulses that are trying to make it down through here get squashed, get killed by the AV node, right? So the overall resulting morphology of AFib WPW is irregularly irregular. A lot of morphologies are wide. Some are narrow. Some are everywhere in between. So you get narrow, wide, everywhere in between. And in some places, you can get rates of up to 250 to 300 beats per minute because that accessory pathway is so happy to conduct a lot of impulses, okay? There's no AV node that squashes a lot of the impulses. So the rates in some places can get really, really fast. Here's the problem that occurs iatrogenically. When you look at this patient and you see irregularly irregular with wide complexes, you may be misled into calling this atrial fibrillation, maybe with the bundle branch block, all right? And if you think this is just AFib with the bundle, what are you going to do? You'll probably give calcium channel blockers, beta blockers, AV nodal blockers. If you mistakenly call this SVT because it's a young person, you may give adenosine, which is an AV nodal blocker. If you mistakenly don't see the irregularity, you may see the wide complexes and you may call this VTAC. And when the rate gets really fast, sometimes it's hard to see the irregularity. And you call this VTAC. And if you call it VTAC, you may just, if it's a young person, maybe you throw some adenosine at them, maybe use amiodarone, which is an AV nodal blocker. And that can cause some real problems. Misdiagnosis and treatment with AV nodal blockers can be deadly. Why? Let me go back for a second. Why is it that these AV nodal blockers can be deadly? Well, again, your AV node was killing a lot of the impulses. When you give an AV nodal blocker, which includes calcium channel blockers, beta blockers, adenosine, DIG, if you're not in a rush, even amiodarone, AV nodal blocker, you shut down this AV node. And the AV node was helping us because it was killing a lot of those beats. And essentially, the impulses just decide to head down the accessory pathway. So now instead of a rate of 250, 300 or so, you suddenly have a rate that shoots up to 600 because it is happy to conduct everything it sees. And that is called ventricular fibrillation. Let me show you an unfortunate case. Here's an irregularly irregular rhythm. It's AFib, and the impulses are changing morphologies, in some places approaching 250, 300 beats per minute. This is AFib WPW, and the patient was given amiodarone, and take a look. Predictable. Ventricular fibrillation. Again, what is amiodarone? If you think about it, amiodarone, though primarily marketed as a class 3 antiarrhythmic, amiodarone also does have class 2 and class 4 antiarrhythmic effects. Class 2, you remember what that is? Beta blocker. Class 4, do you remember what that is? Calcium channel blocker. So amiodarone is part beta blocker, part calcium channel blocker, and if you're not lucky, the beta blocker, calcium channel blocker, in other words, the AV nodal blockade will predominate, And this is what you're going to end up seeing because of its AV nodal blocker and calcium channel blocker, beta blocker effects. And this is borne out in the literature. If you did a lit search on AFib, WPW, IV amiodarone, this is what you'll come up with, a handful of case reports and a very nice review. Everything that seems to be published is about IV amiodarone being given to rapid AFib, WPW, and the patients do worse. I've never been able to find a single case report or case series demonstrating rapid AFib WPW patients getting IV amiodarone and doing better. If you're lucky, maybe that class 3 effect will predominate, they'll do better, but you've also got the AV nodal blockade, which is deadly. So my recommendation is stay away from amiodarone when you're dealing with AFib and WPW. All right, so we've kind of digressed just a little bit. Let's look at a couple of more cases. This was sent by Drs. Nathan Reisman, who is a resident, and his faculty, Dr. Mark Silverberg from State University of New York Downstate, or Kings County Hospital, which is a big, famous county hospital. And they took care of this patient. I don't remember how old this patient was, but this is very classic AFib WPW. Once again, it's irregular. Morphologies are changing, and in some places, rates approaching 300 beats per minute. So what did they do? I forget how they treated the patient, but the patient ended up converting. They treated the patient appropriately, and now you can see the WPW. There's short PR segments and delta waves. So great job there. Here's another one. This was sent by Dr. Tharindu Uyanagi, who has sent other cases before. He works in Melbourne, Australia. He had this relatively young patient with AFib WPW. How do you know? Once again, it's irregularly regular. The morphologies are changing. Some are narrow, some are really wide. And in some places, the rates are approaching nearly 250, 300 beats per minute. This has to be an accessory pathway. You pretty much have to have an accessory pathway for AFib to go this fast. Anyway, he decided to just go ahead and light up the patient. 200 joules works beautifully. Sedate the patient first, of course. And it works very nicely. By the way, these are not chronic AFib patients, so don't worry about dislodging clots, right? Nobody lives chronically in AFib WPW. Nobody is going to live chronically with a rate like this. So when you see AFib WPW, I think it's pretty safe to assume that that's new onset, and you're not going to dislodge any clots by just shocking the patient. And shocking works very nicely. It's fast, it's efficient, it's kind of fun. Sedate the patient first and shock. It works very, very nicely. And there's your delta waves and WPW, short PR, and so on. Next case. This is sent by Sebastian Legare. I'm sure I'm mispronouncing his name, but he is an advanced care instructor and assistant chief of the pre-hospital department at a hospital in Quebec. And this is a 9-year-old that one of his folks were taking care of. Once again, AFib WPW. Take a look at how fast that is. If you map it out, it's irregular and the morphologies are changing. AFib WPW. This young man actually spontaneously converted on his own, but had that not happened, of course, the best course of therapy is sedate and shock, or if you want to use a medication, procainamide is generally considered the drug of choice. This was a case I mentioned last week, Dr. Justin Cook. Now last week, remember, we said this is SVT with WPW. This is the orthodromic, so it's narrow. And I didn't give you the full story last week, but Justin Cook had this patient, and he gave an AV nodal blocker, which normally is appropriate. Remember last week I said if you have an SVT, then you can treat it just like any other SVT. He used an AV nodal blocker. I think he gave the patient some calcium channel blocker. And right after the calcium channel blocker, the patient actually turned into AFib WPW. And again, you see the morphologies are changing. In some places, the rate's approaching 250 beats per minute, okay? And at this point, he just went ahead and he shocked the patient. And after a 200 joule shock, put the patient right back into sinus rhythm. And now you see the delta waves. And I wanted to point this case out, and also the next case, for one simple reason. I don't want to back off on telling you what I did last week. Last week I said if you have a narrow, regular, that's key, it's regular, narrow, regular SVT and WPW, AV nodal blockers are generally safe, but don't get cavalier. Anytime you use an antiarrhythmic, you should always be prepared for decompensation. we get very cavalier with SVTs and think it's not a big deal, but even adenosine is associated with some adverse effects. So whenever you've got tachydysrhythmias, whether or not you're dealing with WPW, be careful and just be always prepared for an adverse effect from the antiarrhythmics. And Justin was ready for it in this case. I think as a routine protocol, I think every time you are taking care of even an SVT, just a plain old mild SVT, you ought to have defibrillator pads ready because you just never know what underlying problem is setting this off. In this case, the patient had WPW, and WPW patients are predisposed to badness. And this is probably a 1 in 1,000 case where an AV nodal blocker put this patient into AFib, but you've got to be prepared for that, all right? So don't be cavalier even about SVTs. And Justin was ready for it, and he shocked the patient very quickly and put the patient right back to sinus rhythm, and the patient did well, although not before maybe Justin had a couple beads of sweat on his forehead. I don't know. He's a pretty cool cookie. And then this is a 17-year-old guy who came in hypotensive and was being taken care of by Dr. Nicholas Taylor, who works in Canberra, Australia. So 17 years old, and he's hypotensive, so it seems appropriate to shock this patient. This is AFib WPW. How do you know? Once again, it's irregularly irregular, so it's got to be AFib. The morphologies are changing, and in some places the rates are getting really, really fast, and that means that this must be an accessory pathway. So AFib WPW, and Dr. Taylor did shock the patient, but again, whenever you administer some type of therapy, you've always got to be ready for a complication, and shocking the patients usually is safe. Again, maybe a 1 in 1,000 cases you shock a tachydysrhythmia, you might develop a complication. And that's what happened here, a bad complication. 70 joules put the patient into torsade. And so no big deal. You've got the pads there ready to go. So you just switch over to unsynchronize and you shock again. And 200 joules, patient went right back to sinus rhythm. So Dr. Taylor got 2 shocks to administer to this patient, and it worked. But again, the point that I want to make from this case and Justin's case is not only to talk about AFib WPW, but also to make the point that any tachydysrhythmia you see always has the potential for instability. So whether you're giving medications or shocking the patient, you must always be prepared for an adverse effect and always be prepared to shock again, or shock the first time if you use the medication the first time. Okay, just to wrap things up, this is AFib with the right bundle. There's no accessory pathway here, therefore use whatever you want. You can use calcium channel blocker, beta blocker, DIG, amiodarone. You can shock this patient. You can use whatever you want, whatever you normally use for AFib, because there's no accessory pathway. How do you know there's no accessory pathway? Well, number one, because the morphologies are pretty much the same all the way across the board. If there's an accessory pathway, you're going to see significant changes in the morphology. And number two, nowhere are you approaching a rate of 250 or 300. If there's an accessory pathway, you're going to have some portions of that EKG that are really, really fast. Here's AFib with the left bundle. There's no accessory pathway here, so use whatever you want. How do you know there's no accessory pathway? Same thing. Number one, the morphologies are all the same. If there's an accessory pathway here, the morphologies would have to be changing significantly. But here, the morphologies are all the same, and nowhere are you approaching 250 or 300. So there's no accessory pathway. When you see those two things, absence of those two things, use whatever the heck you want. All right? So once again, just to sum up, AFib with WPW, it's going to be irregularly irregular. Some complexes will be wide, a lot of them. Some will be narrow. Some will be anywhere in between. The morphologies are changing, and sometimes you're going to get very, very rapid rates. Those are the two cardinal features of having that accessory pathway with AFib. Look for changing morphologies and look for sections where the rate is really fast. And when you see that, stay away from all AV nodal blockers, okay? Stay away from amiodarone as well. That might be a controversial statement, but nobody can use literature to argue against that statement because there is no literature that clearly says amiodarone is safe in every case. There's a lot of examples that are published of amiodarone causing harm. So stay away from all AV nodal blockers, and remember, amio is an AV nodal blocker. All right, so that does it for our mini discussion on WPW. Again, please review last week and this week. Hopefully that'll clear things up with AFib WPW. And once again, my thanks to Matthew Ball, Nathan Reisman, Mark Silverberg, Tharindu Uyanagi, who else? Justin Cook, Sebastian Legare, and Nicholas Taylor for all sending in some really, really fantastic cases that everybody out there who's watching can learn from. I hope that was helpful. And again, use my main email, amalmattu@comcast.net. Don't waste your time searching our website for my email. All right? If there's any questions, email me anytime. And I hope that was helpful, and I will talk to you next week. Bye for now.